just all go home at that point, because anything I say from here on in is going to be downhill, I think. But thank you for those kind words, and thank you also because the support that we've received within the school from the director has been absolutely immense over the last, certainly for the 12 months that I've been here and the time before that. I think the school has dramatically changed, and there's a lot more optimism than there certainly was a few years ago. So on behalf of the school, I'd like to thank you for all the hard work that you do. So cardiovascular care, it's only half time. I've tried to combine the two things I'm very passionate about in the world, and that's both football and cardiovascular care. So over the next 50 minutes or so, I'll take you on a journey that will be a little bit of me and hopefully a lot of cardiovascular care and some of the things that we've done in the school over the last 12 months. So why was a boy from the Welsh Valleys now stood in the middle of Liverpool in a city that boasts the second school of nursing in the country, the second Nightingale School of Nursing? It is the origins of district nursing and the origins of public health. So how did I end up coming here and stood in front of you today? So we'll talk a little bit about the roots of my development. And whenever you put these slides up, you can always see anybody in them just recoils backwards as soon as they realise that they're in the photograph. So on the top left-hand side there is the town I was born in. A town called Mountain Ash in South Wales, very proud mining community, and a lot of my beliefs and my values are founded from that community, a very working class orientated community, and very communal and focused on helping each other. Just below that is the school that I went to. Let me just share with you. It looks very impressive because it's a former manor house. The school isn't there anymore, and let's just say it wasn't the best school to go to. I looked at the Ofsted report recently a few years ago, and I was comparing schools that I was sending to my daughters to, and then comparing it to the school that I went to. And I thought, okay, maybe, to survive that school was probably a major credit to me. But I learned loads about myself in that school, and certainly came away with a lot of positives. On the bottom there, to go to the school, we used to walk to school every morning. We used to have to walk past the Deep Duffering Colliery. And at the time that was open and was churning out all the coal for the rest of the country to be able to manage their fuel. Obviously, growing up in the 1980s, we saw that went into decline, and the valley has changed very much since then. Part of my roots, you'll see in the middle there, family and the support that they've given me, and certainly through my PhD, that when I finished my PhD, and my youngest daughter said to me, "Does that mean you'll come out of the study at night now?" And unfortunately, or fortunately, I don't know, but it didn't mean anything of the sort. It just meant that there was more work to do after. But it's work that I'm passionate about, work that I want to do, so there's a great deal of thanks there. As we move along, you can see the football. This is the one in the second from the right there is me playing for Wales at the Millennium Stadium. I'd love to say that it was a competitive game, but I actually paid £300 to play in the game. And I think the Caris or Sophie still has a video of me after 90 minutes and refusing to come off because I was absolutely dead, refusing to come off. And they've got a video of me walking back from the petrol station, actually like this as I was trying to cross. So 90 minutes at the Millennium Stadium. It doesn't look that big when you're on the side, but when you're actually playing on it, it's very big. And on one occasion, I brought the ball out of defence and I'm charging down the field and I'm sprinting. And then I watched the video and it looked like somebody had slowed it down because I thought I was sprinting and I was actually running at a snail's pace. So I knew then that it was time to give up. So then I moved into coaching. On the right-hand side there, worked with a community group called Lanark Juniors Blackburn Community Sports Club. And one of the things I found there was that many of the skills that I'd had within football, I was able to transfer across to the... I actually coached a girls' team and still coaching the women's team. And that was because my daughter said to me, "Dad, I'd like to play football. And there are no girls' footballs team around here, but I really want to play." And I said, "Okay, if you want to play, we'll make it happen. We'll make you play." So we set up the team within the club, and she went on to end up, she actually did achieve the dream of playing for Wales. I paid £300. She was able to go and put the shirt on without having to pay. So My other children, Adam, who's here tonight, who's just a joy to be around, and Sophie is now working. She's actually got her dream. She did a drama and English degree, and for many years was reading lots of Harry Potter books. And I said to her, you know, you need to focus on your studies. Sophie finished a drama degree. She's now working for the Warner Brothers down in the Harry Potter studios down in London. So what do I know? She clearly knew what she wanted, and she's gone and achieved that. And Caris, believe it or not, said to me after an 18 months journalism degree, Dad, I want to be a nurse. And I thought, this is just a way of trying to get, she doesn't want to do journalism anymore. She's trying to get out of it. She thinks if she says she's going to be a nurse, I'll be so proud. And I said, hang on a minute, I've just spent 18 months on your rent, and you're now going to start all over again. But she's now 12 months into her journalism degree. A nursing degree even. And then just on the top there, Sophie managed to get a face into that one. I looked for a photograph of my parents on their own, and I couldn't find one. They always seem to have a grandchild in every photograph that's taken. So my parents, who pretty much owe everything to. When I was younger, they always pushed me. One of the things I would say is that when I was younger, my dad said to me, you need to get out. There's nothing here for you. You're not going to do anything. You need to get out. You need to get out into the wider world, and you need to do something. I realise now that that was career advice. I just thought it was, he didn't want me at home every day. And as a role model, former ambulance technician, and was able to say, when I talked about nursing, said, yeah, I've worked with some guys in A&E. I think you'll be all right at it. I think he said to me, you'll need to harden up a bit, but I think you'll be all right at it. And again, role models, my mother, who left grammar school to look after my grandfather, who both grandfathers died of pneumoconiosis. My mother left grammar school to look after her father, which was what happened in those days. So there was definitely a caring element within the family. I've put that video up there because in the Druid faith, the oak tree is sacred. And one of the things that they argue is that whatever you see on the surface, actually there's a lot going on in the roots, and the sort of roots there are all those things around me. So without what you see on the surface is founded on the things that have happened within your life. So I think that it's important that we remember those roots and where we've come from. Growing up in the 80s. Okay, so we're gonna do a bit of a test now as we walk through this. So the A-team. The A-team were the only crack commando unit I ever remember that never killed anybody. They actually shot everybody, they all blew up, and they got out of their cars and they waved their fist at them as they drove away. Brookside Close, sorry people, my mother and I used to watch Brookside Close with the subtitles on because we didn't have a clue what was being said. Yeah, that Scouse accent, I've just about got my head around it 12 months later, but we used to sit there with the subtitles on because we could not understand it. Miami Vice, I actually thought I was like a Welsh Don Johnson. Yeah? I had the suit with the rolled up sleeves and everything at a young age. So these were my role models. Okay. Starsky and Hutch, you knitted me a cardigan that Paul Michael Glazer wore, the one that he came out to the swimming pool wearing. And Wham, Club Tropicana, I can assure you that drinks are not free. Yeah? Wherever you go, you do have to pay for drinks. For the young people in the room, that's actually a VHS cassette tape. This is how we used to have to watch films. You used to have to go to the shop, you'd buy them, or you'd rent them, you'd take them back the following day. That's where we got our entertainment from. But then the equivalent of our internet came in. This was CFAX. Yeah? This was where you could read all the news instead of waiting. This was where you could actually book holidays, as Peter Kay famously says. This was that the world had changed. And as we move across, you talk about quest for knowledge. Sit there in a boring evening, nothing else happening, put Bamboozle on and test yourself. Absolutely superb. As we move down, you can see here that you've got this was a video game. This was the video game that all of a sudden we were able to play tennis with each other, playing a video game. Absolutely unbelievable. At the side there, that was a picture of my chopper bike. You went out if you had a chopper or a grifter. They were the bikes that you had when you were a young boy in those days. And this is from Google Earth. This is the street that I grew up on. There's a lot more cars in that street than there was when I was younger. And when you were playing football, it was easy because when you were on a hill, you didn't need anybody else. You kicked it up the hill and it came back to you. Or if you went round the corner, you could kick the ball against the wall and it would come back until the person in that house came out and told you to stop kicking the ball against their wall. On the far right there, Busby always said, make someone happy, ring them up, have a telephone call, until, actually I've made that many telephone calls, my dad put a lock on the phone that you couldn't use it anymore. So you ended up having to use phone cards, and you'd have to go outside to use the phone card. So that's what it was like growing up in the 80s, and the younger people in the room, they'll be looking at that and wondering what on earth I'm talking about, but that was life in the 80s. So career options. When I was a child, the career options were relatively limited. There was going into the mines, and my mother was adamant I wasn't going to die the same way as her father died and my father's father died. When you put into a 5-foot seam and you're breathing in air that is constantly killing you, and eventually it does kill you. So there were different options. They were mainly, in a Welsh mining town, they were mainly the uniformed careers. So the Royal Air Force, I was actually accepted into the Royal Air Force at the age of 16, and then decided actually I really didn't want to go in the Royal Air Force. I just thought it might be a nice thing to do. I went to a medical for the police force and realised that I was colourblind, so that wasn't really going to be chasing a blue car down the road when actually it was purple. That really wasn't going to be a career option for me. So that was a Royal Marine. I wanted to be a Royal Marine, but then I can't see very far. So again, if you're coming out with a gun and you're looking around and thinking, okay, where are they? You'd be dead before you've realised it. So that wasn't an option. Playing for Cardiff City, that's the strip of Cardiff City in those days. There was only one thing that stopped me. I was gutted. There was only one thing that stopped me, and that was ability, or should I say lack of ability. And to be honest, in those days, and actually, to be honest, the way they're playing at the moment, ability shouldn't really affect things because they're actually doing really badly. And then, so at one point, I was toying with another idea, another career option, because you'll see me on the far right there. I was the lead in Joseph and His Amazing Technicolor Dreamcoat. I still, to this day, do not know why I'm over there as the star of the show, and Simon Bradwick, who was just a shepherd, is in the middle. Simon Bradwick must have had a deal with the photographer or something, because he was in the middle. I've circled the lady on the far left there. That's a lady called Sarah James. She's called Sarah Young now. I spoke to Sarah this morning. She's the chief executive of Thornbury Nursing Services. She drives a Ferrari. She has a chateau in France. She has a flat in Bristol and a big house in Edinburgh. I chose academia. So from a financial point of view, obviously Sarah took the right route, and I'm fair play to her for doing that. So my career options were relatively limited, and then I had lots of jobs when I left school at 16 and couldn't really work out what I was going to do. And then somebody said to me, why didn't you think about being a nurse? Well, to be honest, in nursing, the role models of nursing in the 1980s were, I didn't really look like that. I certainly didn't look like that. Neither did I look like that, or definitely not that. And then one person came and saved the day, and he's still doing it. He's still there for male nurses all those years later. Yeah, and male nurses still only make up about 10% of the groups that we take in. So it's still not changed over those years. So we do need to look at how we recruit more men into nursing. But Charlie Fairhead has been flying the flag for male nurses for a number of years now, and we've got a few more in the public domain. So I chose nursing. Where did it begin? There you go, 1987. Fresh-faced, 18 years of age, not knowing one end of a patient to the other, knowing that I wanted to do something to make a difference, but not having a clue how, and reliant very much on the staff that I was working with, the mentors in those days, but very often the third-year student nurses, and we know that happens. It's those third years teach the second years and who teach the first years, and some of the camaraderie around there. And one of the things I would say is I had a tutor called John Holmes, and at times you felt, I'm not sure this is going well, and I'm not sure I've got what it takes. And that's why I value so much the role of the personal tutor now, because we can lose people along the way, not because they won't go on to become good nurses, but there are all sorts of doubts and all sorts of worries and concerns that they have. And it's the personal tutor role that's vital to those people, to reassure them and to support them through those difficult times. That was the nurses' home that I lived in. Now, again, this was 1987, so we had a home warden. And if you weren't home by 10 o'clock at night, you didn't go home, you stayed outside. So there was a a little door around the back, which is actually a fire exit. People would come and open it for you and allow you in. So that was the experience of living in a nurse's home. That was my first ever ward, called Joseph Leckie Ward in Walsall in West Midlands. And walking on that first day, and I remember as if it was yesterday, shaving somebody for the first time and coming away and looking at them and thinking, there was no medical care, no real in-depth care, but I'd made a connection with somebody, I'd spoken with them, they felt better because of something I'd done with them, and that stayed with me forever. So it's not always about the technical stuff. Very often it's about the way you make people feel that makes such a difference to people's lives. That was the nights out that we had. I'm dressed there as a priest. I'm not quite sure who approved the Nazi stormtrooper at the side of me in a hospital social club, but it appears that there were less health and safety and risk problems then than there are now. But I'm sure that girl went on to make an exceptional nurse. But I stayed on the right side. I was there as a priest. So some good nights out in those days. This is a journey really of my career journey. So I started off in a small district general in Walsall in the West Midlands. Nothing fancy, didn't do anything amazing, but what they did do, they did very well, and that was nursing care. I ended up going to Wakefield because I wanted to do the coronary care course. I went to see my manager at the time, and he was persuading me to stay in coronary care because actually I wanted to work in A&E. And he said to me, I'll get you can go and work in coronary care if you stay within the directorate. And I said, okay. And I said, but I want to do the coronary care course. If I'm going to do it, I want to learn how to do it properly. He said, yeah, that's fine, Ian. He said, no problem. He said, you can go on the next course that's free. I said, brilliant. I went back 2 days later. I said, John, I'm on a course. He said, you can't be. There's a 2-year waiting list. I said, no, I've got a place in Wakefield. He said, no, we go to Dudley. I said, yeah, but I've got a place in Wakefield. I'm happy to go to Wakefield to get on the course. He said, you said as long as I could get on a course, I could start. So true to his word, he put me on the course. So I lived in Wakefield for 6 months and then came back and continued to work in the coronary care unit at Walsall Manor Hospital. And I learned a valuable lesson there. I worked with a guy called Phil Jevon, who's now their resuscitation training officer. And when you're young, and I find that I'm probably less arrogant and more humble now than I was then, because in those days I did think I knew it all. Now, the more you learn, the more you realise there's so much that you don't know. But I remember being on a night shift with Phil, and I was all excited, and I wanted to know all the rhythms, and I said, is this? And there was something happened on the screen, and I said to him, Phil, it's there, look. And he said to me, yeah, that's an FLB. And I said, right, brilliant, it's an FLB. He wrote it in the case notes. 5 minutes later, Phil, there's another one of them FLBs. Yeah, write it down, Ian. Got to the morning, the case note is FLBs constantly till 7 o'clock. Sister came on in the morning, I said, and the patients had several FLBs through the night. And she said, Ian, what's an FLB? I said, Phil, what's an FLB? He said, a funny looking beat. And I looked at him and he said, stop being so bothered about what's on the screen and think about the person in the bed. And I thought, that's a valuable lesson that I learned as a staff nurse, because I was so desperate to be technical. I wanted to look at the rhythms and say, it's this, it's that. You know, we've all watched the all exciting programs, but I wanted to do that. And he brought me right down to earth and said, you care for people first and you worry about the rest afterwards. When you can do that, I'll teach you the rest. And I took that with me. So when I was working in coronary care and I'd have staff come on and they say, teach me this, teach me that, I said, I'll teach you when you're ready. Go and learn how to go and ask that patient what it feels like to be lying in the bed and they've just been told they've had a heart attack. So then I went to the Queen Elizabeth in Birmingham. It certainly didn't look like that. There's a bit of a theme. I went to Debbie Roberts, who's here, who I shared an office with for 10 years. I went to Debbie's inaugural lecture recently, and she talked about everywhere she'd ever worked had been knocked down. Well, everywhere I've ever worked has been knocked down because the QE didn't look like that then. So yeah, brand new building now, but I went there, and the reason I went there is because I wanted to know more. I'd worked in coronary care. I was confident that I had an understanding, but I wanted to do cardiothoracic surgery. I wanted to work with transplant patients. I was a sponge and I wanted to know as much as possible. So I spent 2 years working at the QE, absolutely loved it, and came away from there a lot more knowledgeable. But what I found was, technically, they were exceptional. But actually, do you know what? The nursing care wasn't as good as Little Walsall Manor Hospital because that was their bread and butter stuff. So yes, they were great at the medical stuff, but the nursing care perhaps wasn't as good. I then went to Halifax, where I spent 6 months. We'll move on from that. That wasn't the greatest experience. It was a lovely little hospital, but I would just come from a large hospital, and I'm saying to them, we need some bloods, we need to this. And they said, yeah, no problem, we'll get them by Monday. What do you mean? I want them in 20 minutes. I want to know what's going to... Yeah, if we can put them in the lab, and we'll get them on Monday. And I was pulling my hair out with the place. But I was fortunate that I then went to Blackpool Victoria Hospital. Blackpool is the Lancashire Cardiac Centre, and absolutely loved the time that I had there. Worked in the coronary care unit. I set up the cardiology ward there, and worked in cardiac rehab, and worked with some exceptional people while I was there, again, who taught me so much about caring for people. I then went as a nurse manager to Aintree, where I spent 18 months, and as the directorate manager for cardiology. And then went on the far right-hand side, there's the University of Salford. I was at Salford for 16 years. Now, normally, when people leave somewhere, they say, oh, this place was wrong and that place was wrong. I absolutely loved the University of Salford. It was very good to me. The staff there were exceptional. But after 16 years, I realised that the time was right to move on and to go to pastures new and to actually challenge myself. What I've found here is, since moving to Liverpool, that the NHS network around Liverpool is much more accepting of nursing, where in some areas in Salford, some of the NHS areas were predominantly wanting to work with Manchester University. It was very difficult to get into some of those areas, and I wanted to break those doors down, literally at times. And that's one of the things about here. We have the Heart and Chest on our doorstep, which is the largest single-site cardiology cardiothoracic centre in the country, and we have Alder Hey just down the road as well. So for me, it was a no-brainer. It also was when I came to the interview, and I met with people, and I became, within a matter of a few minutes, you think, yeah, these are people I can work with. These are people I've warmed to very quickly. And I've thanked Rafaela. I'd also like to thank Anne Scott, who was on the interview panel that day, who was also very welcoming of me. So things I've learned along the way, just to reiterate really, Anne Townsend, who's sadly passed away now, but Townsend and McCulloch stated, technological expertise without compassionate application is useless. And Debbie will have heard me say this several times to our pre-reg students. Don't get bogged down with all the technology. Learn how to care for people. These are some of the other things I've learned, that communication is vital. Patient has chest pain if she lies on her left side for over a year. Not quite sure people should be lying on their left side for over a year, but these are all taken from case notes that we've had over the years. So that's... Be careful what you write, because it's important how we interpret things. Patient has 2 teenage sons, but no other abnormalities. So, yeah, I can certainly empathise there. After quitting smoking, the patient started smelling again. And the patient is allergic to contrast medium and also 2 of her children. I think they mean that the children also have the same allergy, but maybe not, yeah. The patient who has chronic heart failure is managed without oxygen for the past year. That is quite impressive. Yeah, so managed without oxygen for a year. And probably my favourite, which was one quite recently, well, there's 2 more, from a student nurse's learning diary. During this placement, I regularly exposed myself to the multidisciplinary team. I think there might be a fitness for practice issue there. If we've got students exposing themselves to the multidisciplinary team, I just have visions of a physio being quite... but this is my favourite because it links into the university. The patient has a history of previous problems with his heart, but this has now disappeared since started working in the university. So it's clearly removed as soon as we enter the university, and so that's these are some of the things we've picked up along the way that you just read them and you think. I just imagine being in a coroner's court and trying to read some of these out. Thankfully, these are not my own editions. The other thing that I wanted to talk about there is that I remember standing in an A&E department one day and saying to a patient, he needed an X-ray. I said, just follow the white line to X-ray. About 30 seconds later, he's back again. And I said, have you been to X-ray? Yeah, I've been to X-ray. I said, no, you can't have done. You've been very quick. No, I've been to X-ray. I said, have they given you the film? No. Well, what did they give you? Well, I've not seen anybody. I said, what do you mean you've not seen anybody? What did you do? He said, well, I did as he said. I walked down that white line. He thought while he was on the white line, he was being X-rayed. So again, it's important that we recognize that communication and how people interpret when they're stressed, when they're anxious, is actually really important. So the story so far, I've linked in, I actually started looking at my history, and actually a lot of it fits in, not that far back, but it fits in with the history of cardiovascular nursing. So death rates over the last 40 years have dramatically dropped from coronary heart disease. A lot of that is down to new treatments, but also new models of care, and some of the risk factors, certainly smoking, being reduced. So we've managed to, the British Heart Foundation's goal really is to eradicate heart disease. So we're not eradicating the disease, but people are surviving for longer with that. So the origins of cardiac nursing really is the birth of the coronary care unit. So the concept was identified by a guy called Desmond Julian, who is still regarded as the grandfather of cardiology, and certainly modern cardiology. So he said really he'd got all these patients who were around the hospital all having cardiac arrests, and he said if we put them in one place, then when they have their cardiac arrest, we've got everything close to them, and that was a great idea. They decided to staff these units, but the first people who staffed coronary care units were medics, the physicians. But they didn't want to do it. They got bored. So they said, we don't want to do this anymore. Who else could do it? Well, I don't know. Maybe a nurse. So the coronary care nurse was born out of that. Both Meltzer and Killip and Kimball argued that it was important that nurses were in a position to care for these patients. But it wasn't just about recognizing ECG rhythms. It wasn't just about, it was actually being able to do something about it. So if a patient had a cardiac arrest, it was pointless standing around and saying, oh, he's having a cardiac arrest over here. It's actually, we need to do something about it. And very often your role as a coronary care nurse is to stop that happening. Yes, you can get an R on T ectopic and the patient ends up in VF. There's not a great deal you can do about that. But very often you can identify patterns beforehand, and our job is to stop it happening. So when you get a student nurse saying to me, oh, I've been on coronary care for 6 weeks and we haven't had a cardiac arrest yet. No, that means I'm doing my job properly. Yeah, and that's the thing with student nurses. They recognize, well, they'll say to you, I don't want anybody to die. I want them to survive, but I do actually want to get involved in things. So our job is to stop that happening. And both Meltzer and Killip and Kimball recognized that it was actually the nursing staff that needed to work in there. So let's look at the mortality. Prior to the introduction of the coronary care unit, the mortality rate was 30%. That was reduced to 15% with the introduction of coronary care units. Now, when they looked at the evidence base for coronary care units originally, there was a whole discussion around whether they were or they weren't effective. And the reason being is because the studies that were undertaken actually were really poor quality studies, and there were all sorts of bias within them. In fact, there was one study which made me smile when I read it only recently that compared admitting patients to a coronary care unit to keeping people at home and letting them stay at home and see whether they survived or not. But what they decided to do was, they said, we're going to admit all the women to the coronary care unit. Because if we leave the women at home, there'll be nobody to look after them when they're ill. So we'll leave the men at home and take the women into hospital. I'm not quite sure ethically you can get away with that through an ethics committee these days, but these were the problems of the time. That was further reduced to 6% with the introduction of thrombolytic therapy. So coronary care nurses, they were in there, interpret the ECG in order to detect complications and to adopt a decision-making role in the event of a cardiac arrest. This is, as far as I'm aware, it is still the only paper that's actually looked at in its entirety a systematized literature review. I'm nodding to Robin over there who keeps telling me they're not systematic reviews, they're systematized literature reviews. A systematized literature review which I undertook with a colleague, Martin Johnson, who was both my mentor and my PhD supervisor. And we looked at what is the role of the coronary care nurse. And actually what came out of it was that historically, people had talked about cure. Well, the role was very much about care as much as cure. And patients talked, when we talked to patients, they talked about being at hand and being close by with them. And it was just as much the psychological care as anything else. Patients often use the technology to ask you questions. So they said things like, how is it looking, pointing to the machine. They weren't interested in ST elevation. They were asking a question, how am I doing? But it's much easier to ask about the monitor than it is to ask about yourself. And we followed that up with a study further down the line as well, which came out with the similar results. So the thrombolytic era. Believe it or not, this is the problem with the health service. A Russian cardiologist called Chazov identified in Moscow that if you put this fibrinolysis in a clot, it dissolved the clot. The rest of the world were all chasing defibrillating patients and keeping them alive. Chazov was arguing, but if we open up the artery, this would surely help. It took 30 years before they got that from his idea actually into clinical practice, because people just didn't believe him. Following the GISI trial and certainly the ISIS-2 trial, thrombolysis was accepted as a means of reducing mortality from MI. I was involved in the ISIS trials, and they were landmark trials of their time. So the thrombolysis treatment has the ability to reduce 30 to 35-day mortality by between 18 and 25%. So we've taken another 25, potentially 25% off again, and more people surviving. So they realized that to administer thrombolysis was time dependent. We needed to give it. The sooner we gave it, the quicker. For every 1 minute of delay was the equivalent of 11 days of life. So we needed to give it very quickly. So the patients were coming into A&E, and there were delays. Now, there were delays in the triage, so people reviewing the patients in the first place, people taking too long to record an ECG, and then not having somebody who can interpret the ECG. The decision, okay, I've read the ECG, what do we need to do about it? And then where's the drug? Trying to find somebody with the keys who's going to open the cupboard to be able to give the drug to us. So what they found was, this was in 1994, what they said was, well, actually, who are the best placed people to be able to do this? They can interpret ECGs, they can triage the person, and they can make a decision. Well, it was coronary care nurses. So nurses, again, were stepped up and started to thrombolyze patients, originally in the coronary care unit, but more and more in the A&E department. And the paramedics took that one step further when they started to thrombolyze them in the back of an ambulance on the way to hospital when they were identifying them. The work there that I've cited is Tom Quinn, who's now a professor at Kingston University, and Jane Cornt, who passed away a number of years ago. I was very pleased to start the Jane Cornt Memorial Lecture when I was president of the British Cardiac Nurses. When we developed these, as often happens, is everybody said thrombolysis is a good idea, let's come up with thrombolysis nurses. But the models of care were very different wherever you went, because they were all being set up on an individual basis. So I carried out another systematized literature review where I looked at all the studies that had been carried out on thrombolysis nurses, and we came away with the fact that the actually coordinating care, having somebody who was coordinating the A&E nurses, they were getting the same results as having extra nurses in there. So the model changed a little bit after that. And also the preparation for the nurses. Because coronary care nurses weren't seeing as many thrombolyzed patients and sick patients anymore, we needed to spend a little bit longer preparing them to do that role. So subsequently, following that, I set up the first national cardiac course, which was funded by the British Heart Foundation. It ran for 10 years, and I'm pleased to say, and proud to say, in 10 years, not a single bad evaluation. And many of the cardiac nurses that are now in the country went through that course. They also recognised that it was important that we looked at cardiac rehab. It's okay keeping them alive, but we need to make sure that they get the support and they have an understanding of what the long-term care will be. I'm not going to go through all that with you because, like many of these definitions, why use one word when you can use 300? The World Health Organization, absolutely brilliant at it. But it's ultimately, it's about the psychological, physical and social well-being of a patient. So what was the evidence to support it? Well, reduction in both mortality and cardiac mortality and total mortality, 26 to 30%, and total mortality, 13 to 26%. So it was an evidence-based care. There's evidence that cardiac rehab is also associated with reduction of recurrent infarct and unplanned readmission. So it was reducing mortality, and it was preventing people from being readmitted to hospital. I was fortunate enough to work as a cardiac rehab nurse in Blackpool and was very much hands-on with many of the studies that we did there. We actually looked at the relatives, because what we found was that the patients had a lot of good quality care, but the relatives weren't getting anything. We looked at things like hospital anxiety and depression and quality of life, and we found that actually the relatives were more anxious and depressed than the patients were because they were getting the information. So we set up a service where we actually set up an educational service for the relatives of the patients as well. Then we moved on to the percutaneous coronary intervention. So we knew that dissolving the clot was good, but actually what we needed to do was go into the vessel and either suck the clot out or certainly open the artery up and allow the blood flow back through again. For the first time, this was now becoming a feasible technology. So become the cornerstone of ST elevation MI reperfusion. It is superior over thrombolysis. However, it is time dependent. We need to get the patient from the door onto the table, in fact the call onto the table within 2 hours. Some places in the country you can do that, other places you can't. So if you can't do that within 2 hours, then you would need to still have thrombolysis. Yeah, okay. So then we moved on to heart failure nurses. So again, nurse-led heart failure nurses. We found Simon Stewart and John Horowitz's work there back as far as 2002. I've just got visions of Caris looking at me now saying if I put a 2002 reference down on my assignment, I'd be told that that's not acceptable. But this is historical work, so it's acceptable. As far back as 2002, Simon Stewart's work recognised that patients who had access to heart failure nurses improved in all aspects of their lives, quality of life and readmissions. However, this is something I firmly believe in. Needs can only be met by empowering the patient to manage their own condition. We've got to stop doing things to people and giving them the skills to do things for themselves. And that paternalistic attitude of healthcare needs to change, because the only thing we're doing is we're giving ourselves more work to do and we can't afford to do it. So it's important that we give people the self-care skills. And I'm pleased to say that we've just submitted, it's great to see Paolo here, we've just submitted a Horizon 2020 bid with Graham Smith from this school and others, where we're looking at coaching for people who have certain illnesses and how we manage to support them to stay at home for longer. So that went in this week. Princey Johnson in particular should take a lot of credit, because she just told me what I needed to do and when I needed to do it, which was brilliant working with somebody like that. So heart failure is a palliative condition, so it's vital that nurses have those conversations with people at an early stage. I presented in Australia and I was ripped apart by all the cardiologists that said, you're going to frighten the life out of people, and I came off the stage quite frazzled, and a heart failure nurse and a palliative care nurse said to me, take no notice, love, you're right. And I'll say that'll do me. The people who were actually involved thought I was speaking the truth. So they expanded the role again. One of the things that I did was we had a study which was over 1,000 patients who'd been admitted to hospital with non-ST elevation MI and unstable angina, and we looked at the quality of care they received, but we also looked at their outcomes. And what we found was those patients, regardless of risk, that were in the coronary care unit had much more evidence-based care, had much more access to specialist nurses, etc. And yet the same patients with the same risk in other hospitals were put onto medical wards and told not to worry about it, they would be fine. I then published another paper, which is the coronary care units should care for all at-risk cardiac patients. The British Cardiac Society subsequently changed their advice to specialist cardiac units. I'm not saying it was all down to me by any means. The timing was right, but the work certainly contributed to that change in focus, that cardiac units should consider all cardiac patients, not just MIs. Need to adequately prepare. The study that we did there, we looked at competence in cardiac nurses and recognised that the online course that we delivered was going to evaluated really well and gave them the skills. We developed, Jill Riley at the Royal Brompton, along with a few others and myself, developed the cardiac nursing acute and episodic care pathway, career pathway, so that nurses had an idea of how they progress through the career rather than going off around in a tangent. And then more recently, working with colleagues in Europe and the European Union, we developed a core curriculum for continuing professional development for nurses. The most difficult thing there was to actually get people from all over the European Union, including the Eastern Bloc, to try and tell us what it is that they do. But we certainly developed a core curriculum for nurses across the European Union, which most national societies are now following. So cardiovascular care today. So between 1974 and 2013, standardised death rates declined by 73% in those dying at any age, and 81% of those under 75. So premature deaths were dramatically down. However, the disease for the heart and circulatory system were the second most common cause of death in the UK in 2014. In other words, it's not gone away. It is still a problem. Because people look at the death rates, they think job done. But we need to remember that the disease is still out there and we've still got a lot of work to do. 155,000 deaths due to cardiovascular disease. 27% of all deaths and cancers caused, CVD caused 27% of all deaths, and cancers caused 29%. So where do we go from here? Big differences. I'm from down here, one of these areas, the darker areas. Cardiovascular disease is still a problem in those areas. Look at the northwest, look at Scotland, still problems in those areas. So again, we know that there are different demographic differences, and it's important that we try and reduce that. There's clearly a north-south divide there that we have to consider, whether that's due to deprivation or some of the inverse law that the poorer people get the worst quality care. There's an argument for that as well in some areas. So the prevalence is reduced slightly from 3.6% to around about 3.3%. But that's not a massive difference overall. If we then look at some of the other conditions, atrial fibrillation is on the rise and heart failure is just about plateauing. So it's important that we recognise that. So what will it look like? In 2013, there was 1.7 million episodes related to cardiovascular disease in NHS hospitals. So it's still people are requiring hospitalisation. If we look at obesity, I love that drawing at the top, the evolution of man, where he stood there with his fizzy drink at the end. Being overweight or obese increases the risk of multiple diseases. We know that, especially type 2 diabetes. Percentage of all adults overweight or obese, so that's either BMI or greater than 25 or obese greater than 30. 67% of men and 57% of women are classed as obese. Big numbers there. In England, 44% of women and 34% had a very high waist circumference. But the really worrying thing is when we look at the bottom, 30% of boys and 29% of girls were classed as overweight or obese. So we've got another generation that are coming through that are already overweight at such a young age. Hypertension is a problem, we know, but that's plateaued out again. So we're managing that reasonably well. We know that it causes heart disease, but the prevalence is around about 31% over the last few years. Anybody that's ever heard me teach taking a blood pressure, if you don't do the blood pressure right, then you don't get a decent measurement anyway. So it's incumbent on us to make sure we're measuring blood pressure accurately. People who suffer from diabetes are 3 times more likely to have a heart attack compared to those without the condition. So diabetes is a problem. We know that with people being overweight at a young age, they're more prone to type 2 diabetes, they're more prone to a heart attack. So we're storing this up for the future. Recent data shows CV burden attributable to diabetes is on the rise, not surprising. And the prevalence of doctor-diagnosed diabetes has increased from 2.9% to 6.9% among men and 1.9 to 5.6 among women. So again, it's on the increase. 3.3 million patients diagnosed with diabetic in 2013. That's a hell of a lot of patients. High cholesterol is an issue. Blood cholesterol level is positively associated with coronary heart disease in both middle and older ages. And 56% of men and 7% of women have cholesterol levels higher than the norm. So all these factors, all these risk factors, we're still higher than they should be. Smoking, thankfully the smoking has reduced because of the smoking ban has certainly had an impact on that. More than half in the last 40 years, from 46 to 19% in 2013. Poor diet, I don't know about you, but when you look at diet, my head looks a little bit like that in the far right-hand corner. Because when they say things like average intake of fat should account for no more than 35% and saturated fatty acids no more than 11% of food intake, I don't look at my plate and think, there's 2% there, there's 4% there. So we need to get better at giving the information that people can understand. I've actually stood in shops looking at the label on the side thinking, I've no idea if this is good for me or not, because yes, it's got low fat, but it's got high sugar and it's got high salt. I can't work it out. How can anybody else work it out? We need the guys from down the road in nutrition to help us there. Percentage energy intake of both fat and saturated fat exceeds the recommended levels. We know that. Yeah, again, it's just above the normal level. So we know that people our salt intake is high, and we know that their fat intake is high. Physical activity, I love that one. The problem is that obesity runs in our family. No, the problem is that no one runs in your family. In England in 2012, 67% of men and 55% of women aged 16 and over met the recent physical. That surprised me, I must admit, when I looked at that. I thought, but it's self-reporting. And that's one of the problems we've got, is if somebody says to me, how many times have you exercised this week? I've exercised every day. Yeah, I'm not quite sure what exercise was. It was walking from the train station to Tyne Barn Street, but I've exercised. So we are reliant on self-reporting. Again, the concerning thing is the 5 to 15-year-olds, 21% of boys and 16% of girls met the physical activity guidelines. So about a fifth of children are actually meeting the physical activity guidelines. So we've got, again, problems building up. If we take that into the graph next to it, looking at young people, you can see that activity levels in children, in both boys and girls, has dropped in the time frame that we've looked at there between 2008 and 2012. So what does cardiovascular nursing look like? This was a study that I did up in the Western Isles. It wasn't the worst place to be doing a study. It was very pleasant up there. We evaluated their cardiovascular risk screening program. Nurses be at the forefront of acute care. Yes, of course, we still need to focus on keeping people alive and doing all that fancy stuff. But there are sustained levels of disease prevalence, increased prevalence of diabetes. Over half of adults have high cholesterol levels, there's high salt intake, high fat intake, worsening levels of physical activity in children, increasing number of children overweight, and there's an increased financial burden on the NHS. So these are all storing up for problems again further down the line. So we need to rectify this and start to think about the public health approach rather than just sticking plasters on things. And we need to have a clear evidence base for many of our public health interventions. And we're fortunate in this school that we do have many public health nurses that can certainly support the research that we do in that area. This is another one I wanted to throw in there, just because from a research point of view, traditionally, a lot of the medical research charities have spent their money in the Russell Group universities because that's where the medical schools are. But if we look at from a 2005 to 2014, the amount of money that's been spent on prevention from £29 million to £101 million. From £27.7 million for disease management to £71.4 million. So they're starting to get the idea, and there's more and more money out there for health research, and certainly this is where nurses and the other allied health professionals that we have and social care professionals within our school are able to contribute. So what are we doing within our school at the moment? We're currently co-creating a new model of cardiac rehab for the South Asian community using a live-in labs approach. We're very fortunate within the school. We have Graham Smith, who's developed the live-in lab within LJMU. And so we realise that Asian patients don't turn up to cardiac rehab. So people say, well, why don't they turn up? Well, why don't we just develop a service that they are co-creating rather than developing something and then wonder why they don't turn up. So we're developing a new cardiac rehab service. We've got funding from the CCG for that, which we're hoping then will lead to an NIHR grant. How do people make sense of a cardiomyopathy diagnosis? One of our PhD students, Jenny, who's with us today, is actually looking at, well, when you're given a diagnosis of cardiomyopathy, how do you actually understand it, interpret what's being told to you? The journey that you've been on can often be quite convoluted. So how do we make sense of that? And we're looking at both clinicians and patients. We're currently doing a study exploring the way in which we coordinate resuscitation. The first day was last week. What I love about the opportunities that we have here is our students are involved in the research. We mentioned earlier on that involving our undergraduate students in the research process. So instead of me standing there and telling them about Heideggerian phenomenology, they're actually there, they're actually seeing it. And we've got people in the room who took part in that, so thank you very much for that. Cold as ice, this is a study that has been undertaken. Aaron, who's with us today, predicting risk in cardiovascular patients using ice therapy. Those people that are involved in this study, they'll think that's not the correct title. These are commercially sensitive studies and I don't want to give too much away. So I'm being cagey on what I'm telling people. So we're dipping people in ice. No, we're not really. And looking at cardiovascular risk. Assessing perceptions of risk in paediatric cardiac surgery. Robin Lotto has been given or rather was awarded a Florence Nightingale Fellowship to explore paediatric risk in cardiac surgery from the parent's perspective, and that's going on at Alder Hey. What are the experience of adolescent girls living with a sternal wound post-cardiac surgery? Laura Kinsey is actually doing this work again with Alder Hey, and we know that adolescents have a sternal wound, and certainly the girls. How do they deal with that? How do they manage with that sternal wound and the effect that has on their body image? And also, what are the experience of caregivers following a heart start? We're working with colleagues over in sport and exercise science. One or two of these projects actually are with people from sport and exercise science, because we like to look outside, both outside the school and outside the university, to do the research, to make sure that we have all the skill set in place, but also to ensure that it's truly multidisciplinary. Just to show that my role is school-wide, so some of the other pieces of research that are going on. What is the diabetes knowledge of health volunteers in Thailand? Pia, who's Rafaela's supervising, is looking at that at the moment, and we've been developing a survey to do that. Developing a new model of bowel cancer screening using the Living Labs approach. I met with the Bowel Cancer Network, and they said, we actually give 21 appointments a day and roughly 7 people turn up. And we don't know why they don't turn up. So we said, well, why don't we develop a new model and we'll bring them in and we'll evaluate it and find out what's going on. So we're using the Living Lab to develop a new model of bowel cancer screening for the Bowel Cancer Network. Developing and evaluating an online healthcare resource for refugees and asylum seekers. Philomene, who I think is in the room, yep, she's at the back hiding, is developing an online resource for health professionals to support people who are refugees and asylum seekers. Philomene's is a Mary Seacole Fellowship. For those nurses in the room, you will know that Florence Nightingale and Mary Seacole are the two prestigious nursing awards. As a school, we've got both within 12 months, so well done to all the people that are involved in that. And patients and clinicians' perspectives of living with diabulimia. Sandy, who's in the room, might think, actually, that's not the title, but that's what we've agreed, isn't it, Sandy? Yeah, okay. So we're doing that. Again, I was interested to see how people don't take their insulin so they can stay, certainly the young girls in particular, they don't take insulin so they can keep their weight down. And that obviously has an impact on their health. This was one that I was involved in recently. I didn't know anything about breastfeeding babies beforehand, but I was literally just doing the transfer on this to investigate the nature and background of bottle refusal by breastfed babies. I did the internal transfer, read loads about that, and I actually consider myself to be quite an expert on it now, to be honest. I had no knowledge in advance, but I really do feel I know a lot about this now. I didn't even know it existed. And the Horizon 2020 bid that I mentioned earlier on with Paolo. As has been said earlier, we've set up a cardiovascular research group within the university. We have 35 members of staff. I met with Gillian Hutchin when she took on the role as the director of the Institute for Health Research, and I said, I've got all these cardiac people out there, and nobody's pulling them together. Can we do something with them? And she said, of course you can. Okay, that's fine, I'll do it. We then went to meet with some of the colleagues out in practice, and they said, actually, we'd like something like that. So now we're looking to have a cardiovascular research group across the Liverpool City region, which is both academics and clinicians working together on these projects. We're in the School of Nursing and Allied Health, but actually it's always known as the Lambanana building. So that, for me, the reason I put that up there is because I've been here just over 12 months. It is my first professorial post. I'm more than happy here, so I'm hoping it will be my last. But I wanted to say thank you to everybody that's been here. When I arrived, I was told they don't do research there, they're teaching only. And then we did the survey, and we said, actually, 189 papers, 47 book chapters, and 7 books had been produced. So they do it, they just need a bit of support and they need some guidance and help to do that. And so that was partly my role. It's about confidence building, making sure that people are on board with what we're trying to do. And I'm going to embarrass Julie Barrett now, because in the beginning, when I said at the outset that I was going to people and say, we need to do research, I was interviewing some pre-reg students this morning, or interviewing for our pre-reg program, and Julie came along and said, you know, we're doing the nursing associate program. I said, yeah. She said, can we do some research on that? And now they're coming to us with the ideas because we've got that opportunity. So it's incumbent on us, to our undergraduate nurses, to give them, we talked about roots at the beginning and my roots. Well, I think it's important that we also have the wings to be able to fly. So this is my final slide. If I had 2 wishes, I know what they would be. I'd wish for roots to cling to and wings to set me free. Roots of inner values like rings within a tree, and wings of independence to seek my destiny. Roots to hold forever, to keep me safe and strong, to let me know you love me when I've done something wrong, to show me by example and help me learn to choose, to take those actions every day, to win instead of lose. Just be there when I need you, to tell me it's all right, to face my fears of falling when I test my wings in flight. Don't make my life too easy, it's better if I try, and fail and get back up myself so I can learn to fly. If I had 2 wishes, and 2 were all I had, and they could just be granted by my mum and dad, I wouldn't ask for money or any store-bought things. The greatest gifts I'd ask for are simply roots and wings. So that's a homage really to my parents for providing me with those wings, but it's also a message to our students that we need to give them the roots that they feel strong within the university, but to give them the skills and knowledge to be able to fly and enjoy their careers in the same way as I'm enjoying mine. So thank you very much.